You're live. All right, good morning. This is St. Patrick's Day, March 17th, Senate Health and Welfare. And we are looking at an amendment that Katie has put together for us. And just on the miscellaneous judiciary bill, S-193, and we've talked about this in here with the secure forensic facility and how to deal with some of the more difficult cases that come out of judiciary. I did talk with DL, DMH, or AHS generally, and I did talk with Ledge Council after our last meeting on this, and we had made some comments about what might work. So Katie's put together some language that might work, but we'll have to go through it. The other part of this is that the institutions committee is very interested in it because it's a DOC forensic facility. They want to weigh in on it. If we can get to a place in here where judiciary is okay, where institution is okay, and we're okay, then we might have a proposal that can go ahead for everyone. We'll have to look at it and see, and we'll have to wait and see what our peers say. That's where we are. So, Katie, you want to start us off? Sure. With what you've got. Is it posted yet? I think, yeah. Not posted yet. Posted. Not yet.
Good morning.
Good morning.
Katie McLean, Office of Legislative Counsel. Pull it up. Okay. So this is an amendment. After hearing some of the concerns, I raised some of those concerns with DMH. DMH provided some draft language that I taken and modified and put an amendment structure. So that is where we are today. I would not say that this is DMH's proposal because I think there are enough changes that were requested that it has morphed. It has morphed a bit.
That's okay. We'll all morph together.
Okay.
We'll see what we can do.
So this is instances of amendment because we are not making changes to the whole bill. We're sort of making isolated changes related to clinical standards. So there is a section in the bill, section 4, where forensic facility is defined and a person with a qualifying condition is defined. In that section, there is a subsection B. And what this first instance of amendment does is it strikes out the subsection B that's in the House Senate Judiciary's version of the bill and puts in this new subsection B. And you'll see there's a mix of unhighlighted and highlighted language just to show you what came over from Senate Judiciary and what is being added by this new amendment in this first instance. So it would read that the Commissioner of Corrections shall establish and operate a locked, secure forensic facility for the secure evaluation, treatment, and care of individuals who have been transferred pursuant to sections 4815A and 4819A. Those, if you remember, there were 2 ways to get into the forensic facility: somebody not competent to stand trial and somebody who was found not guilty by reason of insanity. So that those crossovers this mean. The Commissioner shall operate the forensic facility in a building that is separate and apart from a correctional facility, including both a separate entryway and dedicated staff to serve persons transferred to the forensic facility. The forensic facility shall be designed and operated in a manner that supports a therapeutic, recovery-oriented, and trauma-informed environment comparable to a community-based residential treatment setting, while maintaining appropriate levels of safety and security. The forensic facility shall not refuse any persons it is ordered to admit and shall not require any clinical or diagnostic prerequisites for admission. Page 2, the forensic facility shall provide for the safe housing and management of persons, including the ability to separate the population by sex and to otherwise address clinical safety or operational considerations as appropriate. including the possible operation of multiple facilities if required by the clinical needs of transferred persons. Fourth, the forensic facility shall employ a clinical services director to oversee all forensic, clinical, and competency restoration services provided to transferred persons. Subdivision 5, the forensic facility shall implement staff qualifications, licensure, training, and supervision requirements that are sufficient to ensure that persons transferred to the forensic facility have access to clinically appropriate care, treatment, services, and supports consistent with individual needs and with applicable professional standards. And ensure that persons receive clinically appropriate assessment and treatment planning, including the development of a person-specific treatment plan within 72 hours following transfer, which shall be reviewed periodically as clinically indicated. So those are the changes to that subsection B, sort of describing what a forensic facility might look like in terms of physical setting and staffing, planning, treatment planning. And then the second instance of amendment starting on line 17 is a new section that has not previously existed as part of the bill. So we're amending the same section that had been previously amended, which is the sort of the definitions where the forensic facility is defined, that is amended in the first instance of amendment. And this is adding an annual report about the forensic facility that's being added at a later date, because we know that it will, one, take a while for the forensic facility to be up and running, and then it'll be a while before there's data to report back on. So this is an annual report that's being added to the Green Books, but at a later date than when everything else takes effect, which is why it's in its own standalone section. So this adds the subsection G, that annually on or before January 15th, the Department of Corrections, in consultation with the Departments of Mental Health and Dale, shall submit a written report to the House Committees on Corrections and Institutions, Human Services and Judiciary, and to the Senate Committees on Institutions, Health and Welfare and Judiciary, addressing the number of persons served at the forensic facility during the previous calendar year and the types of clinical services and treatment provided. So that's an annual report. Line 10, this is our third instance of amendment. Right now, the bill contains language about emergency rulemaking. This proposes to strike out that section about emergency rulemaking that came over from Senate Judiciary and put a new rulemaking section in. Part of what the rationale for the difference here is the version of the bill that is coming over from Senate Judiciary has the bill taking effect this year, which is why there's language about emergency rulemaking so that rules go into effect right away. However, as this has continued to move and there have been continued conversations, it sounds like the various departments involved will not be ready to have a forensic facility up and running anytime in the next 12 months. So there's really, if we push the date out to align when the work will actually be ready to be done, then there's no need for emergency rulemaking and you can just do regular rulemaking. So that's sort of the change that's happening here. This language says that the Commissioner of Corrections, in consultation with Departments of Mental Health and Dale, shall adopt rules to implement the provisions of sections 1, 3, and 4 of the Act. Those all do with the forensic facility. Specifically, the rules shall establish clinically appropriate standards governing the provisions of services at the forensic facility, including requirements related to staffing patterns and ratios, staff qualifications, licensure and training, clinical supervision, and the delivery of safe, effective, evidence-informed care. And standards for quality assurance and improvement, clinical oversight, documentation and reporting requirements, safety and risk management protocols, and mechanisms for monitoring compliance. And any other provisions necessary to ensure safe, effective, and clinically appropriate implementation of the 3 sections on the forensic facility. Oops, and then I need a space here. Okay. And that brings us to the fourth instance of amendment, which is on page 4, line 6. This is striking out, section 7 of the, Senate Judiciary Report, which is just that the effective date is July 1, 2026. And it replaces that section 7 with a section 7 and 8. So a new section in section 7, a reporting section, and then a section 8, an effective date section. So there's a new interim report requirement under this amendment that by October 1 of this year, the Department of Corrections, in collaboration with DMH and Dale, is to submit a written interim report to the same policy committees containing draft rules required pursuant to section 5. The interim report shall also address the status and anticipated timeline for the adoption of rules under the Act, forensic facility planning, including space considerations and design elements necessary to support a therapeutic and secure location, initial staffing considerations, including anticipated staffing levels, required qualifications and potential contracting needs, and an anticipated timeline for the development of a forensic facility, including preliminary cost estimates and initial operations. That's all part of a one-time report that would come to you this October. And then a new effective date section, because we talked about how we have some tiering happening. So this section, meaning the effective date section, and section 2 of the Act, which doesn't apply to the forensic facility, takes effect July 1, 2026. Section 2, I should maybe skip to 3. 3 has most of the sections taking effect January 1, 2028. So that's when all of the language about the forensic facility would take effect. And then the subdivision 2, talking about section 4A, that would take effect on July 1, 2029. So that would take effect a year and a half. That's the reporting requirement, the annual reporting requirement. So a year and a half after a forensic facility could be operational. So there would be no annual reporting until the forensic facility has been operable for those 18 months. That's it.
We're probably gonna have to go through it all again.
Sure.
Be good. And I'm looking at, Karen and Claire and your comments on what is here. So why don't we go through it a little slower this time and look at each section? And understand what's there, and then raise your hand if there's something that you see that should be discussed.
Okay, so our first instance of amendment, again, we're striking out a subsection B that's in the Senate Judiciary version. We're putting a new subsection B in, and our highlighting shows what language came to you from Senate Judiciary and what you're adding. So we have language that the Commissioner of Corrections shall establish and operate a locked, secure forensic facility for the secure evaluation, treatment, and care of individuals who have been transferred pursuant to the Act. The Commissioner shall operate the forensic facility in a building that is separate and apart from a correctional facility, including both a separate entryway and dedicated staff to serve persons transferred to the forensic facility.
Okay.
So me, thank you, Chair Lyons. I just wondering, because last week we heard from WellPath and we're talking a lot about the commissioner and the agency. Can you remind me what WellPath's role will be in this?
Maybe a better question for the administration, but it sounds like WellPath will be providing the services, including competency restoration services for this population.
Got it.
Joe, question.
Well, just a comment. I'm not sure where this separate facility has come from. That's my question. And I'll hear more in my other seat in the institutions, but by example, I know we're desperately working to look at a new women's prison, and that's going to take 3 to 5 years. And when I look at this and I go separate building, separate staff, I don't know where that comes from, under the time frame that we're also looking at this bill. So,
Good question.
No, I was just wondering, kind of the same thing, kind of the same thing as Senator Benson. The commissioner shall operate the forensic facility in a building that is separate and apart from a correctional facility. Can that just be a wall in the same building?
I think potentially, I think it could be on the campus of a correctional facility. Separate and apart from a correctional facility,
Right.
but
I don't know what that means exactly, separate
Yeah.
apart. I mean, I'm just envisioning one big building with some form of separation in it where you could do something perhaps.
I think that's possible, the time frame, but I read it as a completely separate.
Well, that's what, yeah, I'm not sure.
seems like there could be no mixing of population.
Right, with separate entranceways. That's what caught my attention was, I think it could be in the same building.
So for the record, Karen Barber, General Counsel of the Department of Mental Health. So this was not our language and we do not support this language. We feel like it is putting the cart before the horse. The idea, we propose the language starting in line 16 through 19. This language takes away the ability of AHS and DOC to look at its facilities and determine where is the best placement. It takes really all of that ability away. And what we had wanted was the ability to look as an agency with the facilities that DOC has. Again, remember, many of these folks are already in DOC. We're also talking about 3 to 5 people a year, so it's a very small population. And we wanted to make sure that we had the flexibility to determine where is the best location for these individuals, taking into account therapeutic, recovery-oriented, and trauma-informed environment. And so we would ask that we continue to have the flexibility to make those decisions. Again, that's something that would have to be reported back before any action was actually taken. And that's something that we would put in that interim report, but we are asking for the flexibility to determine what is best for us.
Okay, so I understand institutions is talking about the paragraph that's above your paragraph, the lines 12 through 15. So if without that, what guarantee is there that there would be sort of separation of populations?
So there's a focus on this separation of populations, which I guess many of these folks are already in our systems. They're already mixed. Again, like if in the mental health context, right? Everyone is all together. We don't separate based on populations. And so it's not like these folks are any more dangerous than other folks or somehow more vulnerable. DOC needs the ability to manage its population in a way that's safe for everyone. And this kind of artificial separating folks because there's some idea that because they're incompetent or insane, they can't somehow be in a situation where they are maybe around other people. I think it's too soon to say that. Again, I think what we are really asking for is the flexibility to design the program based on the realities of DOC and the realities of staffing and the realities of facilities. Again, this is such a small group of people, right? 3 to 5 people a year. We're not talking about a large population. We're talking about folks that are already in these situations. And we're talking about how do we get them more supports, not less? And just because they're separated doesn't guarantee that they're actually getting better care or better services. It's kind of I think, an artificial thing to separate on. What we're trying to say is let's focus on the quality of services. Let's focus on safety and clinical needs. And then let's let the agency and the departments really think about what makes sense for the rest of it right now. Because again, this is more a broad authority to design a program.
Okay, before I go to you, I'm going to ask the question I had when you started. Go ahead.
I understand, thank you for that. I understand the question or the tension between the location of the facility What about like lines 12 to 15? Says that the commissioner shall operate the forensic facility. Are you all okay with the commissioner operating?
Yes,
Okay.
Yeah.
So it's just really a question of the location.
of the, how it's designed, yeah.
Would it fix the problem if it said like the Commissioner of Corrections in consultation with AHS and all the various parties? Would that be a possible resolution?
I think the issue for us is lines 13 and 14 is the separate and apart. And the separate entryway and dedicated staff. It will have staff, but of course, but that doesn't mean that, you know, the staff couldn't also be serving other people. I think we have to remember the economy of scale, right? We're not talking about a large population, so to try to carve out and have to pay for everything over here may not practically or financially make sense. And so what we're really asking for is the flexibility to allow DOC and its departments, and sure, I think this will be done when you get down to kind of the rulemaking. It would be all of us, but we could certainly add it here if there's a concern that DOC is the only one looking at it, because that's not the idea. But the idea is that we need flexibility to determine. Does that kind of answer your question?
Yeah, it does. Thank you.
Two questions. One, knowing that the issue around separation is going to continue, is it possible to say something about shall consider?
Absolutely.
Can we put that in, embedded in with lines 16 through 19? Somehow, yeah.
Shall consider whether separation makes it.
How, if and how.
Yeah, I think leaving it flexible, I think it's certainly something that it makes sense for us to look at. But
But we don't know where it is right
we
now.
don't know where it is right now, right?
We do that. Okay, so try that. Then other, okay, sorry, go ahead, Katie.
Doesn't quite fit in there with.
Well, where
the
it is,
lead-in. I'll figure it out. Okay, sorry.
You're a lawyer, you know that.
Okay.
And then the other one is, so some of these people can't stand trial, so they're innocent, but they're incompetent. Yeah, they lack competency to stand trial, so they're innocent. And I've heard this complaint time and again that gee whiz, they're innocent, you can't stand trial. Why are we putting them into a secure facility? I know some of the answers there, but I want to hear the answer from you.
Sure. Sorry. I was trying to see everyone. Because the court has made a determination that there is no least restrictive option to preserve public safety. So again, remember, we are only talking about individuals that have been charged with the most serious crimes and who are being held without bail. And the court has found they remain a danger to the public. And so what we're trying to do is address that gap. If the court says they could be in the community, then they would be in the community receiving services. The reality is some people, even if they're incompetent, are dangerous. And we have to have a way to address that. And that is what we're trying to do. That's the gap. That gap is current. It's right now. We've seen negative outcomes of it. And if we don't do anything, that gap will remain. And that's what we're going to do.
Thank you. It's really helpful. And I know that judiciary worked very hard on that in that specific area and looked at other states. So I always remember the teacher over in Caledonia County that was kind of a thrill murder. And I believe the person that actually committed the murder was found incompetent. But the mastermind is in the woman's prison. And I remember that. I'm not sure that those are people you want out until you're quite sure, you know, that they're safe. Okay, so we'll move past that and then go to the next section.
Okay, can I, but I just say what I think I heard and where I think I'm gonna add changes? Is that okay? Okay, so I think I'm gonna add this concept to the rulemaking. And I'm also wondering, you have an interim report coming back, and it seems like when we get there, that might be a place to ask for a more detailed plan as to the physical facility.
That work.
because you have a highlighted adoption of rules. So yes, add that. Okay, and so you have your list of the forensic facilities shall be designed and operated in a manner that supports a therapeutic, recovery-oriented and trauma-informed environment comparable to a community-based residential treatment setting while maintaining appropriate levels of safety and security. Not refuse any persons it is ordered to admit and shall not require any clinical or diagnostic prerequisites for admission. Provide.
Back to that, it says in a residential treatment setting, so that again comes into that whole play of what is the facility? That's kind of predetermined.
It is giving guidance, as they plan. So that's a policy decision.
That was not EMH language.
That was not what?
That was not our language. We wanted it to be a little bit more flexible so we could determine. I mean, I think
I
what we
would
heard
want-
from WellPath is that they're essentially providing outpatient services.
Right.
You know, there's lots of levels of residential services, so it's kind of unclear, frankly, what this means. You know, we do have one secure residential, but that's the only residential that is locked. Again, I think instead of focusing so much on those, I think the pieces that we're trying to focus on are, you know, what kind of treatment is provided? Who are the clinicians? How do we do it in a therapeutic environment without tying the hands of the agency in terms of how we're designing it? We can work with that language, but since you're raising it, I just wanted to highlight that it wasn't something we added, and it's a bit more prescriptive than we had initially hoped for.
Where did that language come from? That here, that was in here.
You asked for it.
I did, yeah. I don't know why would we have the clinical or diagnostic prerequisites not required, because that's the point.
Oh, that came from Senate Judiciary.
That's what my question was.
Oh, I thought you meant about
So
the
they
therapeutic
put
setting.
that- So let's leave it. I don't want to change it.
Okay. That sounds like I have to go up to the House floor in a minute. Okay. 3, provide for the safe housing and management of persons, including the ability to separate the population by sex and to otherwise address local safety or operational considerations as appropriate, including the possible operation of multiple facilities if required by the clinical needs of transferred persons.
That was annoying. I think that's fine.
Subdivision 4, employ a clinical services director to oversee all forensic, clinical, and competency restoration services provided to transferred persons. Implement staff qualifications, licensing, training, supervision requirements that are sufficient to ensure that persons transferred to the forensic facility have access to clinically appropriate care, treatment services, and supports consistent with individual needs and with applicable professional standards. Ensure that persons receive clinically appropriate assessment treatment planning, including the development of a person-specific treatment plan within 72 hours following transfer, which shall be reviewed periodically as clinically indicated.
So the 72 hours was fine. Previously, there was just nothing. There was no time in there. So I suggested to have a time frame within which there's some attention.
I wonder if I might suggest adding the word initial, just because it will be,
Yeah, no, that's exactly what.
they'll need more time. But I think that's a fine time to have an initial, just knowing that that would be kind of preliminary. They wouldn't have enough time to really develop a relationship plan, but that makes sense to me.
Yeah,
We
we didn't want them
we
just
left
sitting
it
there for months and months and months. And wait a minute.
I think I said reasonable, but yes, that makes sense.
Okay. Then you have the addition of your annual reporting requirement. By January 15th, the Department of Corrections, in consultation with DMH, Dale shall submit a written report to the policy committees addressing the number of persons served at the forensic facility during the previous calendar year and the types of clinical services and treatment provided. Maybe that should also say during the previous calendar year.
And our only concern with that one, is it leaves out BDH. Again, we had put AHS initially. It's fine if you want to list the departments, but substance use is a major component of this. And so we want to make sure, that we're acknowledging that. And so the Department of Health should be named.
Okay. Makes sense.
5, wondering if this is the same thing about rulemaking at BDH.
That was my only comment on that.
Commissioner of Corrections in consultation with various departments shall adopt rules to implement the provisions of the act related to the forensic facility. Specifically, they shall address clinically appropriate standards governing the provision of services at the forensic facility, including requirements related to staffing patterns and ratios, staff qualifications, licensure and training, clinical supervision, and the delivery of safe, effective, evidence-informed care. Standards for quality assurance and improvement, clinical oversight, documentation and reporting requirements, safety and risk management protocols and mechanisms for monitoring compliance, and any other provisions necessary to ensure safe, effective, and clinically appropriate implementation of this act. And this is where I'm going to add, including potentially requiring the provision of forensic facility services in a unit that is separate from other correctional populations. So that's where I'll include that idea.
Okay, that would be good.
Okay. Then you have your interim report by October 1. The department in
And so
consultation
does
with
the
other
Department of
departments.
Mental Health need to be back into this one too?
Yes, please.
Okay.
Department of Health.
I got it. I knew what you meant. Shall submit an interim report to the policy committees containing draft rules required pursuant to section 5. It shall also address the status and anticipated timeline for the adoption of rules, forensic facility planning, including space considerations and design elements necessary to support a therapeutic secure location. I'm wondering if that's where you want to be more specific about what the plan is for the physical facility.
I hesitate to do that simply because I know institutions is gonna look at this.
Okay.
And they do physical facility. I know this, everybody's in everybody's jurisdiction right now.
I will hold off on adding anything there.
But what would you put there, Katie?
Let's say forensic facility planning, including
Space.
a detailed proposal of where the forensic facility would be located. The timeline for having it fit up, design elements necessary, something like that.
Okay, I wouldn't mind that being added. We'll let institutions approve or make improvements.
Guess this may be from Department of Mental Health. Where are they now?
So it depends. Some are in corrections, and some are
In the community?
Mm-hmm. Which is one of the places where we had a problem. And it's, can you share with us the expense for someone in a community facility 24/7 as compared with what might happen here? Just what, if someone's in the community, what does that mean for the security of that community place?
So if someone, say has been found incompetent, for reasons other than mental illness, or it is mental illness and maybe they're on an ONH, that doesn't necessarily guarantee they're in any type of housing. Those orders are really meant to, if it's an order of non-hospitalization, they could be in a residential setting, but they also could be living on their own and receiving services at a designated agency. If they're not connected to the mental health system, it could be that they're receiving outpatient substance use treatment. It could be they're receiving, outpatient services through the DA for intellectual developmental disabilities or a TBI or dementia. So it really looks different based on the person. As I said, there's only one walk facility. for mental health. No other department runs any other secure facility. So that's the only one outpatient secure facility. So if you're in a residential setting, it could be in staff 24/7, not necessarily though.
Go ahead.
Page first, so I recall there were two different ways that these individuals go through the system. One was, they get put into a facility. The judge says, no, you gotta be too much of a danger, you're going to DOC, I guess.
I want to clarify what you mean.
Yeah.
There are two ways for people to come
Yeah.
into the forensic facility?
Yeah.
Okay,
Go ahead.
so, I just want to make sure you don't mean that that somebody with a mental illness was a clinical need for hospitalization.
No,
No, okay,
so go ahead and explain the two ways that they.
okay. So there are individuals who are found not competent to stand trial. That's not a clinical diagnosis. That means that the judge is finding that they can't communicate with their attorney, or they can't understand what's necessary to mount a defense. So they're not competent to stand trial. They could be transferred to the forensic facility, and there would be competency restoration service to try to make that person competent to be able to have their trial. The other way is that a person is found not guilty by reason of insanity. That doesn't have a bearing on their competency at the time that decision is made. That is a decision about the person's capacity to understand what they were doing at the time the crime was committed.
So how are we getting them in our communities then?
Well, if somebody is found not guilty by reason of insanity, then that's the end of their trial. They were found not guilty, so they could go back into the community unless the court finds that at the time that decision is made, that person has a clinical need for, let's say, mental health treatment, in which case the court could order somebody to have involuntary mental health treatment for however long their medical condition lasts. But again, being found not guilty by reason of insanity isn't a decision about the person's mental state at the time that decision is reached.
And this is the loophole here that we're trying to address.
This is a problem.
Yeah.
It's ongoing. It's ongoing. It's a problem. So here's what my suggestion will be. I think we've been through this a couple of times. Our comfort level, I hope, has gotten a little bit better. What we'll do, we have this on schedule tomorrow morning. Don't we, Calista? Yeah. Yes. Well, we will. We have Katie in at 9:15. And we do have one bill that we're gonna be taking off of this order.
That's Thursday, though.
Now, that's a Thursday.
I know, I
I'm
had the
looking at
same thought.
Thursday, okay.
I had the same thought. So you don't have me at all tomorrow, looks
I
like.
don't have you. What about Eric?
I could do, let's see, I could maybe do an 8:30 or 8:45, something like that, if you wanted to just look at the changes that I'm making right now. If the house my bill is in, I don't know, I'm too away from my bill, but I could sit here and do your changes now.
Okay,
Give you something to look at
Let's do
this
it.
afternoon,
Yeah.
later this morning.
let's see what we can do with that. And
Okay,
then,
let's see what I can put together.
we'll try to come back to it. We're resisting going to the 8:45 number. Or the 8:30 number.
Okay, I'll see what I can get done right now. And even if we don't have an edited draft, maybe we could just look at.
So far, the changes that we've made are okay with
Yes,
the agency. That's good. Okay, great. Thanks. That's great. We're on a roll. All right, so what we're looking at now is with Tucker, who is here. Thank you. Have you been in this committee this year? Once. No, wait, for the report? Didn't come in? Oh, we're glad you're here. And I think we'll introduce the members for you because you haven't been.
John Borley, 408.
John Benson, Orange.
Jenny Fines, Chittenden Southeast.
Hello, Red Table Marking of Chittenden Central.
Well, wonderful to meet you and re-meet the committee in general. For the record, Tucker Anderson, Legislative Council. From what I understand, I'm here this morning to talk cannabis. Is that right?
That is accurate, and let's be as narrow as possible with respect to the sections of the bill that are within our jurisdiction. So anything to do with dosage, anything to do with marketing to children or marketing that might be considered going to youth. And I don't know what else we might have in store for us.
Well, I think you will be glad to hear that if you're taking a look at draft 3.2, which is the recommendation from the Committee on Economic Development, Housing, and General Affairs, you'll note that all of those issues have been removed from the bill as introduced.
And, oh, wow. And so what about the excise tax for the prevention dollars?
That has also been removed.
Oh,
So the THC content limitations were removed. The advertising updates were removed, and the lowering of the excise tax was also removed. Now, the individual transaction limit, which is not related to dosage, just how much an individual can purchase in a single transaction, has been raised, and so has the possession limit. It might trigger, for example, civil or criminal penalties, has proportionally been increased based on the transaction limit. Packaging limits have been increased so that an individual package can have twice as much THC as it formerly would have under current law, but otherwise the concentration caps aren't adjusted. The advertising provisions.
okay. So basically what is in the bill relates more to economic development and finance than it might to this committee. We can go through and look, maybe do a 10,000 to 25,000 foot walk over.
Terrifying to walk at 25,000 feet, but I will try to do. The first section of the bill increases the packaging. The way that was described in Senate Economic Development is you are no longer saying you have to exclusively purchase 6-packs. You can now buy a 12-pack. Transaction limits are increased from.
And just to, I know, this, we're gonna get to these places. I'm empathetic with what you're chuckling about. Just to remind ourselves that, while there's an interest in changing the cannabis at the federal level from Schedule 1 to something else, still THC still has potent pharmacological effects. And so we've had a fairly robust regulatory environment in Vermont to start. And so this is really continuing that look. There, change hasn't happened in Congress yet. So we're still under the same regulatory umbrella at the federal level that we have been. Is that right? Is that accurate?
Yes, the status of cannabis at the federal level has not changed. There's been an executive order indicating that the federal agencies are going to rapidly reschedule cannabis, but that would not be descheduling and making it a commodity in general commerce federally. It would be lowering THC from Schedule 1 to Schedule 2. Okay. Sections 2, 3, and 4 all deal with the transaction limit, which is being increased from 1 ounce to 2 ounces. And in sections 3 and 4, what's happening there is that it's increasing the amount that an individual can carry on that person without being subject to civil penalties.
Can I ask a question here? So these changes are all legislative changes. What role, if any, would the board, the cannabis board ordinarily play in making these decisions?
So I can point you to one thing that is not changing with the status of the transaction limit that the CCB is involved with, just as an example. And that is that the transaction limit is calculated based on weight measurement for cannabis flower, but there are also cannabis products that are manufactured. And the CCB has discretion to determine how that transaction limit is calculated for purposes of the cannabis products. So you might have the transaction limit of 2 ounces for cannabis flower, but what does that mean for vape cartridges and edibles and other products? Well, the CCB determines through rule what that transaction limitation would be, and then communicates that to the retailers who put it into a system that calculates based on a person who is potentially purchasing both flowers and products, so that as they're scanning through, they know when you come to the individual transaction.
Okay, so that just dipped right into our jurisdiction. So you said they, others.
So I don't know the stuff very well, but I take it hashish is a derivative of marijuana
It is concentrated.
or concentrated. We're doubling that to
5 grams to 10 grams proportionally to reflect the transaction limits. Sections 5 and 6 establish 2 pilot programs. The programs are slated to be effective for a 2-year period. The first is an event permit. There will be 20 of these issued per year for 2 years. And the events are fairly broad and what they would cover. It's limited to 10 public events and 10 private events per year. And those could be catered events on the private side, such as a wedding. And on the public side, you could think of something like the brewers or winemakers fests, where you have individual stalls. Could be farmers market permit that is issued.
So anyone 21 years or younger would not be eligible to participate in any of these products, whether at an event or otherwise.
Correct.
And so is within the bill, is there some guarantee that that's being overseen?
Yes, it's restated in each of the permit sections. The CCB ultimately oversees these events. There's a requirement for security built into each of the permits. And the CCB is given procedure authority that will operate with the same force of law as rules in order to put certain restrictions and requirements on the issuance of these permits. Okay.
So it's not dissimilar from what happens with alcohol.
That is correct. And in fact, the next permit that I'll describe to you is the language is taken directly from the Title VII regulations. For the delivery of alcohol, there's going to be 15, not more than 15, delivery permits issued per year as part of this pilot. And that would allow individual licensees to deliver from their licensed establishment to an individual who is 21 years of age.
First of all, where are we exactly in the, are we on, George? Can you give it up?
I can certainly try to join.
Are we on
That's
section
my
six?
technological-
Are we looking at delivery permits or are we?
Yes.
Okay. That's on.
And I have another question. 7, wow. Way behind. So you ready for my second question?
Yes, I'm gonna try to multitask for him, Senator.
Or I can wait. Okay. So with the delivery, is there, upon delivery, is there a requirement, maybe there is, and I just haven't seen it, to show identification that would, show the age of the person who's receiving the package?
I don't think so, but let's pull it up and work together.
Oh, delivery permit, page 7, okay, section 6.
There is not an express call out for checking ID. The holder of a delivery permit may deliver cannabis and cannabis products sold from the licensed premises for consumption off the premises to an individual who's 21 years of age or older. And then later on, subdivision 4, an employee or agent who's making the deliveries shall complete a training program approved by the CCB. Similar requirements exist for those who are making deliveries from second-class retail establishments to individuals in Vermont under the alcoholic beverage statutes, and the requirement as part of that training from DLO, and I can only tell you what happens in reality, is that checking identification, verifying identification is part of the training that an individual has to go through before they can sell or furnish alcohol or deliver it under one of these permits. So same structure, not expressly called out. The assumption would be that yes, identity verification.
Senator Gulick and then Senator Cummings.
I have never received alcohol in the mail, but I do know people who have, and they have told me that the person who delivers the alcohol takes a photograph of their ID. So it's like it's verified. There's a photograph. I don't know what they do with the photograph, but I'm just letting the committee know that that is a procedure that I've heard, and I'm wondering why it wasn't included in this.
So to be clear, with alcoholic beverages, you have a much more open market, including the issuance of licenses in this state for direct consumer mail delivery of alcoholic beverages. So those are third-party common carriers like FedEx, UPS, DHL, whatever, that are delivering those boxes, taking a photograph of the ID, transmitting those records back to the individual licensee who's selling the alcoholic beverages. That is not contemplated here. Why? Because cannabis is still illegal at the federal level and can't be transmitted through the U.S. Postal Service. And some of those larger national delivery companies are apprehensive to participate in this market. This permit only allows an employee of an entity that is already licensed and regulated in the state to transport in a vehicle that is owned by that establishment cannabis to the end user. And the employee or agent is going to have to go through training. You could absolutely add something in here stating that part of that training or part of this process has to be some sort of identity verification. But that is already happening with the license held by the entity who's delivering the product if they were selling it from their licensed premises.
Have to get so at the point of sale, there's an ID, but not at the deliveries.
Could be.
Got it. Okay, thanks.
Go ahead.
I was on economic development when a lot of these laws, we started out with the goal of helping our local breweries. And so and we had distributors that wouldn't carry the local things because Budweiser dominated the market or somebody, I'm not sure. I'm not so sure. My votes, we allowed local delivery of alcohol, but we found out because it wasn't illegal federally, but cannabis may not be illegal federally a year from now, that we had to allow out of state delivery. So you go to California, and I did do a wine tour in California, and I was asked how come we can't ship to Vermont. You can now go out to Napa and you find something you like. You can have it shipped to you with regularity. And it was in the laws. I remember that the UPS driver did have to get ID. I'm not sure that if we're doing this, we want I think we need to recognize that the possibility that cannabis could become legal, and that would mean it, nationally, or that we would have to allow. We allow in-state shipping. We're going to have to allow out-of-state delivery.
So what I'm
I'm
gonna
getting
suggest,
concerned when I go to my farmer's market. And as the number of farms has declined, the number of distillers and brewers seems to have increased. And it's some point, I'm not sure what I'm really at. Is it a farmer's market or is it a beer and alcohol tasting event at 7 o'clock on Saturday morning? And I just think we need to consider what we've learned. Is that what we really want to do?
so my suggestion is that we go through the bill and then because we're gonna have two more folks testifying from Department of Health. Oh, I know that.
And I am not a teacher.
No, you got it. I understood. You're raising important points. Okay. Go ahead. So where are we?
We're moving through section 6, which was the delivery permit pilot program. Section 7 ensures that the holders of these permits during this 2-year period are going to be paying the excise tax. Moving all the way to section 10, at the end of the first year of the pilot program, the Cannabis Control Board is directed to report back to the General Assembly on any issues that have come up, whether or not the program is successful, and whether it should be allowed to repeal at the end of the 2-year pilot, or whether Title VII should be updated to incorporate either the entire program or some portion of it indefinitely. In section 11, there are updates to the local government provisions, specifically allowing individuals to petition for the opt-in vote, which is not something that is currently contemplated under 7 VSA section 863. So this would extend to the voters of the municipality the opportunity to petition to put the opt-in vote on the ballot. And then further on in that section, there's an existing exception from conditions on the issuance of a local permit for purposes of nuisance abatement for outdoor cultivators. And this is amended to extend that to indoor cultivators and tier 1 manufacturers. Section 12 changes the schedule for the distribution of license proceeds to municipalities. Section 13. Yes.
Chair, this, you may not have an answer for this, but I know that in my Senate district, there have been issues around the conflict, I would say, between right to farm and nuisance. That sometimes comes into issue. Well, I mean, you know about this too in your district, not with cannabis, but is there, do you know if there's any work being done around that there is around that conflict? Okay, I have people nodding, so it sounds like there is work being
It's
done.
handled in a separate bill though.
Right.
It's just,
Yeah, okay, thank you.
Great.
in section 13, there's an adjustment to the terms for employee licenses and extended product registration for shelf-stable materials. There are a whole bunch of repeals. So the integrated license is going away. And because it is going away, or potentially has already gone, we are repealing references to integrated licenses throughout Title VII. Which brings you all the way to the bottom of page 20, the top of page 21, which deals with cannabis business development grants for cultivators, manufacturers, and economic empowerment businesses. It expands the type of entities that are eligible for grants under this CBDF fund. The next three sections, starting from section 24, all deal with updates requested from the Department of Tax, specifically related to cannabis business expenses from household income, the use value appraisal program and its applicability to outdoor cannabis cultivation, updating a reference from parcels of land to definitions from the CCP. And finally, allowing the department to share return information from some of these cannabis licensees with the Cannabis Control Board. So it's an exception from the mandatory confidentiality that's applied to tax return information.
So I have a question here first. So within the original bill, it's introduced, there was a stamp being placed on vapes. No, that's the other bill. Sorry, done.
I have that.
Yeah, you have that.
That's my question.
I had,
This is an S bill. Does this committee have it?
Hmm.
This is an S bill.
yes,
Does this committee, is it in this committee or is it in mine?
which bill?
This one.
This bill is not anywhere except being voted out of economic development up on the floor. I don't know whether it was referred to your committee or not.
I hope it was because
What number is it?
passed up in it. I haven't had a chance to go over everything that comes out. Okay, so it's on the floor and we are looking at it, but we do not have possession.
Yes, it's
Okay.
on the floor. We're taking a
And I'm
look at it.
assuming we have.
If the sections that have been taken out were still in it, we would probably be wanting to have a longer look at it. And we may, after we hear from the Department of Health, have some more things to say. Questions for Dave Tucker?
Sorry, I know. I thank you, Madam Chair. I may have missed it, but I don't think I did. So I'll ask the question. Is there any contemplation of adding any kind of further educational programs and I know the excise tax goes to education, but is there anything in here that is explicit around educating our children on the complexities of, no, okay.
No change to whatever the status quo
Got
is.
it. Thank you.
There are some other bills in play that deal with after school
Yeah.
and summer wraparound programming.
And some other
Sales tax.
It's not in the four corners of two seventy.
Got it. Okay, thank you.
And I have had a conversation with the Director of Prevention, Department of Health, about how we can wrap our arms around the prevention fund that is here and what the current requirements are for it, and then what more we may want to do. So we're going to have that discussion. It's a really good question.
Good. I can't wait. I will hold my comments until that time.
On appropriations, she said, in 2027, $1 million is transferred from the general fund, cannabis business development fund.
Is that a question or?
Well, I'm reading in section 28.
Well, when it gets to appropriations, we'll look at that $1 million and we'll make a decision about the best place. So the $1 million in here is for,
You got there's two parts to the appropriations. You also have 1.68 million going to the Land Access and Opportunity.
yeah,
So
I think they're investments in the business itself. So it's business development. It would not be appropriate to take this out of the excise tax that goes into the prevention fund. That is my position, our position, I think, of the committee.
I thought it was sales tax that went to prevention. Is it the excise?
Yes,
That's-
sales tax goes to the education related funds, including the universal after school and.
Yes, okay, that's the one that was the big forfeit. Because sales tax got sent to the education fund between, this bill took a long time to pass. Between when the cannabis bill first was discussed and agreed in concept and when it actually got passed. So it's the excise that goes to prevention, which, sales that goes to after school and other. But I thought that was being raised as prevention service.
So we're gonna look at that, we'll look at that in here, we've got a lot. But I
Sitting on my wall, so we'll be looking at it.
let's move to the other folks who are here to testify. There's Sheila Livingston, and Tony Folin. And, but each of you from Department of Health.
Hello.
Thank you, Tucker.
Yeah.
We may not be finished with you yet, so. Okay, well,
Hi. I'm Sheila Livingston. I'm the advisor to the commissioner of the Vermont Department of Health, and Tony Folland. Let's do this. I Zoom. Tony, do you want to introduce yourself for the record?
Hi, for the record, Tony Folland, Clinical Manager for the Department of Health, Division of Substance Use. Nice seeing everyone.
thanks for being here. Appreciate it.
Okay, so do you want me to just say my piece? Okay.
That would be great.
I will do that. So we really want to start by saying we like the version that came out of Senate Econ, but much better than the version that was introduced. For many of the reasons that you've already heard, but I'll just summarize them briefly. We are looking to maintain some of the public health safeguards that were originally put into Vermont's cannabis regulation law. Critically, we would like to maintain the existing THC potency caps, concentration limits, and single serving package limits. We would really like to maintain the existing purchase and possession limits. And we would like to maintain the advertising rules to decrease any chance that we'll see advertising about the regulated. A couple of those, the most important two, are not in the bill that got passed. You guys.
Sorry, Sheila.
Oh, no,
What'd you say? I'm sorry.
yeah, I will say that again. So of those pieces, the potency caps and the advertising were taken out of the bill. And so we really appreciate that. So I won't dwell on that unless you all have questions, because the bill as currently in front of you no longer has those pieces in it. So appreciation for that to start with. We would like to ideally maintain the single serving package size and possession limits. And those are raised, as Tucker just explained, in the current version in front of you today. So substance use prevention is similar regardless of the substance for the most part, right? And when you increase the amount available to people, and that is therefore available in the common environment, you just have more substance that people to use more of. And they're at one time more that a younger person can access at one time. And then the other pieces of the bill we're not particularly focused on. I think just generally, again, for public health, when you increase access to a substance, whether that's the number of outlets that sell it, the number of places where you can obtain it, just to increase additional exposure and use in society. But we don't have specific edits there at this time. Happy to answer questions.
so you're asking to have change made, so was the change discussed in economic development?
Yes, so we sent a version of the bill with some edits to both Senate Econ and to you all. And they took, again, the most important ones. So again, just want to appreciate that. The pieces that they did not take from the changes we recommended were the purchase and possession limit increases. So those were made in the bill.
So, and I'm kind of looking at Tucker, are those increases as part of a pilot program, or are they permanently maybe?
They are not part of a pilot program. They are permanent adjustments. And
Okay, questions, other questions for, Sheila? Thank you. That's good. Thank you for your comments. And
We can't wait to come in and talk to you about prevention later this week.
Okay. Well, then I'll add my question then.
so let's go to Tony Colin. Tony, do you have anything else you would like to add? I know you've been here before. You have a lot to offer and we appreciate it.
I do not, Chair. I really was hoping that just to be able to answer any kind of more technical or real substance related questions that the committee might have to support Shayla in this.
Okay, so I do have a question, I guess, as we're talking about this, but what data is there that demonstrates if you increase the quantity available that we're going to see sort of misuse?
Do you
So
want
we
to?
actually,
Okay. No, you do it.
sure, we actually have some of that data that we've seen within the state using both National Survey of Drug Use and Health as well as behavioral risk surveillance data. What we've seen actually since the decriminalization of cannabinoids, that adult use has tripled. So as we've seen the reductions in risk, we've seen a tripling. And what we've seen since the since the legalization in the open market is we've seen a slight uptake in numbers across the board. And when we did surveys of people who are using the market, they said 65% have reported that they are likely to either start or increase their use.
Thank you. Senator Gould, but along those lines, have you also collected data on the increased number of sort of we've heard and we know that there are sort of mental health consequences to utilization of cannabinoids over time. And so one illness being schizophrenia. And so do you have data on that you could help us understand? And knowing that the questions that we're asking now will be helpful when we start talking about prevention, but do you have that data also?
We don't as a formal link in the state of Vermont. What we do know by looking at just national research is that the correlation between the onset of folks with experiencing psychosis is often related to their to a level of substance use. It doesn't appear to be causal, but it's certainly correlational that folks who use cannabinoids are more likely, if they have an underlying propensity for a psychotic illness, to have that triggered.
Right, got it.
I would, may I answer too?
Sure.
I think that the other thing is that that is a rare outcome.
Yeah.
And that there are much more common health impacts that we see around depression and anxiety and dependence. I think there is still this myth that you cannot become dependent on cannabis. And Tony, I don't know if you have the stats on that off the top of your head, but I think that those are much more common, and those are the things that we could be tracking and potentially seeing an impact here in Vermont as that use, like Tony says, goes up so much.
Yeah. I think what we've seen is I believe it was the Breakfast data, that looking at particularly adolescents who use marijuana more frequently. So I think the number was 20 days or more in a month, that we see almost 25% of those folks experiencing suicidal ideation. And so the link between depression and cannabis is quite high, particularly for folks who are using cannabis regularly. And then with certainly the potency limits, which is less of a concern now, the higher potency cannabinoids, you start seeing 30% of folks developing cannabis use disorder, which then you have to consider the more available, the more folks are going to use themselves, the higher the health impacts that are going to occur.
And health costs.
Yep. Senator Gould.
Several decades ago when I was a teenager, but and cannabis was not cannabis was not decriminalized at that point, and people were obviously using. So my general sense of like the war on drugs is it didn't work, doesn't work. So in theory, I believe in decriminalization because it has worked in some countries actually, when there's enough of an investment in education and in healthcare. My question is, I'll make that statement and I'll ask my question, which is, when you look at the data since we have made the changes here in Vermont, what's the increase, if there is one, in like teen usage? Do you have numbers around that?
We do, and we can get the data that Tony was saying and the data that we have to you. I don't want to speak on the exact changes in both categories. The increase has been much greater in the adult population than in the youth population. So I can tell you that off the top of my head. I think one thing, the war on drugs, right? Like, we know that was not an effective tactic. And I think I want to really impress on the committee again, like when we think about prevention and regulation of substances that are legal. So now cannabis is legal in Vermont. So nicotine, I'm going to use nicotine, alcohol, and cannabis, right? Helpfully, the tactics are similar. And so what we can say from our experience with those other two substances that have been legal for a lot longer is potency matters, density of outlet matters, places that sell it being like attractive to kids matter, right? All of these things have real consequences for initiation of use, which we're really worried about, and frequency and potency of use. And so, I think to try to bring it into the history of those substances where we have a lot more experience regulating, when we come to you with some of these recommendations, if we have that kind of decades of knowledge from those other pieces. That's also
It is helpful. I also was part of the discussion a few years ago about the prevention money, and students in Vermont spend the bulk of their day in school, and the folks who teach about drug abuse and about how drugs and work, et cetera, are the student assistant professionals, the SAPs. And I've been talking to a lot of folks in the field because they feel like they're losing this battle right now.
Mm-hmm.
And they feel that there aren't enough SAPs in our schools. I know in my district, we have 3, and it's just not enough to do a proper job of educating kids on what this is all about. And I'll just leave it at that. I feel really torn, but I don't want to punish the cannabis growers and the cannabis retailers. And at the same time, if we are inadequately funding the prevention in our schools, which is where, we always say in education, like, meet kids where they are, that's where they are. And they just don't have the resources to get a proper education. And so I'm just going to send that out there as my concern right now.
Yeah, and we are going to come in and do kind of a full conversation about the funding that we have in those types of programs, and those programs are really critical. And I think this committee is just eyes on making sure that money, like the chair said, stays with prevention. It's very, very important to us and to Monica Hutt, the governor's office. We want to make sure that funding is used for.
So, and just so you know, I cornered them all in the hallway and they all promised to come in. So great, we're going to do that. It's an important part of our job. Yeah, thank you. Okay, we're good. I think we're going to have to come back to this tomorrow and have a short discussion about what we do, if anything, with respect to an amendment on the bill. And Tucker, thank you for being available. So that's the end of that discussion. We have 2 people in the hallway who wanted to share with us something about a business that they have in Washington County. We're going to have to thank you about and Senator, let's set these arrests.
I'll be right back. I'll move with alacrity.
And Katie did send another draft. And I'm gonna just quickly, we'll look at it. We'll look at it today. I'll get it to you, to everyone. Karen, you and Claire and us around the table, and then see what we can do to agree. Good morning. So our time is legislative time, and I especially need to be somewhere at exactly 12 o'clock, but we've invited you in. Robert Squire and Mike Howe are here to share with the committee a praxis. And so help us understand what that is. And you can move up together or sit where you are.
I'll sit here. I'm in
Okay.
support mode.
Okay, that sounds good.
Well, thanks so much for having us. I really appreciate the opportunity to introduce ourselves. My name is Rob Squire. I'm a founder of a company called Praxis. We're a Montpelier-based company, a healthcare company. Mike Powell is also a co-founder. Our Chief Clinical Officer, Carrie LeCompte, couldn't join us today, but thanks so much. Wanted to just introduce Praxis to tell you a little bit about what we do as a Vermont-based company in the field of healthcare. It's a very innovative company. We're doing some interesting things in the space throughout the rest of the country. We don't yet work here in Vermont. Maybe we'll change that sometime in the future. I don't know if anyone is familiar with the field of medication therapy management. That is what it says, where we help manage medications therapies. Our prime customers on Medicare plans want to improve health outcomes and find cost savings. Probably every one of us knows somebody who's on an awful lot of medication, right? How do they get on all this medication? What does the pink pill do versus the blue pill? Is there an opportunity to prescribe some of these medications? Are any of these medications interacting with one another to cause you to get back to the hospital? Is there a more cost-effective alternative? All of these are the questions that medication therapy management addresses. And when we address them, we can improve health outcomes and find cost savings. Simple as that. CMS requires every Medicare plan to have an MTM program as part of its design. They contract with companies like Praxis, and we provide this service today for the largest Medicare plan in Puerto Rico, the fastest growing Medicare plan in Florida, other Florida plans, the smallest, on the other side of the spectrum, the smallest upstart Medicare Advantage plan in Massachusetts. We also have customers in Arizona, New York, and elsewhere. But where we don't yet apply the most innovative aspect of MTM is in Medicaid. What we're hoping to do is to bring MTM and medication optimization to Vermont Medicaid to unlock all of that health outcomes and cost savings. As we all know, an aging population and the rise of chronic disease, people are going to be taking more and more medication. Vermont had a 54% increase in your pharmacy spend in 3 years from 20 to 23. How do you stop that if you don't pause to look at the medication therapies and say, where can we improve this? How did this person get on 12 medications? What better therapy optimization could we apply to get those savings and avoid all those downstream hospitalizations? So that is what we do. And we've actually done this work in Wisconsin. We were the original MTM provider for Wisconsin Medicaid. And because we were the technology partner that created the backbone of that bellwether program that proved that this works in Medicaid environments, we actually have the lived experience to know what works and what doesn't work. And if we had the opportunity to speak to the state of Vermont and the Medicaid department, we could create a really great program.
Can you tell us what MTM means?
Medication therapy management.
Thank you.
Yeah.
I know you said.
And to that, we add optimization. We're not just managing the therapy, but we're optimizing it.
I'm sure, does this somehow tie into Blueprint, or could it potentially tie into the?
Theoretically, it could tie into Blueprint or any other layer. It could be within a payer organization. It could be at the provider level, which is Blueprint. Yeah, it could. So, but it's a business that's up and coming, and Senator Perchlik introduced me to both of you folks and suggested this would be something helpful for us to understand. And we have talked in here and continue to talk about quality metric analysis, and this is certainly a piece of it.
Yeah.
Yeah,
And it's also important because it's also economic development too.
sure.
Because we have the opportunity to build good healthcare industry jobs here in Vermont. Obviously low environmental impact, good paying jobs, good career paths. And so we are a venture-backed company, and the venture capital firms that invested in Aprexis were almost all Vermont venture capital firms. So it's actually a very interesting story. The state gave money to the venture capital firms. Venture capital firms invested in Aprexis. Aprexis would like to work for Vermont Medicaid to provide health outcomes and cost savings and build jobs that will build revenue back to the state and a dividend on their investment. It is an economic development win, but we have to close that last piece of that gap. We need to be able to prove this out with a contract to Vermont Medicaid.
Thank you.
Yeah.
So we're at 12 o'clock. The pumpkin is appearing, and we're going to call it a wrap for today, but appreciate your coming in and sharing your visions with us.
Thank you.
All right, that's it. We'll go offline. I tried.